All right, there we go. And Dr. Bunch, I will hand it over to you. The one other thing I should mention, if anyone has questions that come up during today's presentation, do feel free to utilize the chat, and we'll have time to go through questions at the end of today's hour together.
Thank you, Erica, and thanks everybody who's able to join us right now and anybody who might be watching later from home. Like she said, I'm Marjorie Bunch. I'm a physician at Albany Med, and I specialize in the treatment of seizures. And I typically see people anywhere in the age range from adolescence all the way up through adulthood. And my talk today is on seizures in older adults, which is not rare and something that I think is just not talked about enough. People don't recognize the significance. So I'm happy that you guys are going to learn more about it today. I don't have any disclosures. No one pays me to talk about things like this. I'm going to start off by talking about who is having seizures when we talk about older adults. Who am I talking about? Who might be affected by this? And then I'm going to go into a little bit about how older adults might be different when they come to see me versus a younger adult or a child. What do we think about when we're evaluating somebody who's older and having a new onset seizure disorder or seizure-like symptoms? What else could it be? What do we have to think about? How do we evaluate it? And when do we decide to treat it? And what do we need to think about when we treat it? How are older adults different from younger adults or children? So to start off, who's having seizures, how many, and why? All right, so this is a graph showing how often seizures happen based on age. And this is combined from a couple different countries, and you can see it's pretty much the same everywhere. There's a U-shaped curve. So early in life, seizures can be pretty common. And I think everybody thinks of kids when they think of seizure disorders. And you can see on the left-hand side of this graph that it starts out pretty high up and then it falls pretty rapidly. So new onset seizure disorders don't tend to happen when someone's in their 30s or 40s, but certainly it can happen. On the left-hand side, you can see this is incidence per 100,000 people. So starting in the first year of life in infancy, it can be as high as 150 out of 100,000 people. And then it really dips down. It's pretty low for several decades. But then starting around age 50, it goes up a little bit, and then 60, 65. And then the curve really starts to slope upwards really kind of steeply. So if you look at our oldest population, which is really 80 and above, it's higher than it is even in the first year of life. So it's not uncommon to see people coming in with new onset seizures later in life. And actually, if you look at all people 60 and over, it's more common for them to develop seizures even than looking at all children. And then the other really interesting thing that I didn't really know until very recently is that not only are seizures common to start having later in life, but over time, over the past decades, it's actually become more likely than it was in the past. So I like this graph here because you see back in 1973, again, we're looking at incidence. So this is new onset cases in out of 100,000 people. It was down near 50, which if you remember from the graph on the last slide, that was like the lowest part of the graph was around 50. So looking at people who are 65 years of age and older, it was really low back in 1973, but then going up over time, solidly increasing, so that in 2013, we're above 150 per 100,000 people. So I think that's really significant. It's telling us something about epilepsy in older adults. So US Medicare is an easy way to get a lot of information on a lot of people by looking at Medicare information, looking at diagnosis codes. And in the US, generally Medicare is people who are 65 years of age and older. The prevalence, meaning how common it is to have epilepsy in the Medicare database, was about 11 people per 1,000 patients registered. So that's about 1%, which is pretty consistent for epilepsy overall in the population. And then the annual incidence, meaning new cases that we're developing, was about 2.4 per 1,000. And that number is actually really similar to the number of people who get colon cancer every year. But if I think about ads and awareness and campaigns and things like that, I see a lot more for colon cancer than I do for epilepsy in older adults. So I just feel like the awareness really isn't there in the population. And all these numbers add up to, in the United States, there's over 100,000 new cases annually of epilepsy in someone who's 65 years of age or older. One of the risk factors that seems to have come out is in association with age, or sorry, in association with race in older onset epilepsy. So this slide combines information from two major studies, one looking at Medicare, and the other is a study that was looking at, it's labeled here ARIC, that's an atherosclerosis risk in communities study. And both of them found that having a Black race really increased the risk for developing epilepsy as you got older. And this chart's kind of busy, but you see among the white population, the rate per 100,000 was right about that 1%, the typical, but then in the Black population, it could be about double. And then other races, which I think were mostly Asians and Native Americans, were lower. So why? Where do these numbers come from? Why is it changing over time? What are we looking at? So to compare seizures and seizure disorders in older adults compared to younger adults are more likely to have seizures related to birth injury, but they're likely to have seizures that come out early in life, not later in life. Same thing with febrile seizures. That can be a risk factor for epilepsy, but usually comes out earlier in life. Recreational drug use tends to be more when people are in their teens and 20s and less of an issue later in life. Functional seizures is the newer terminology for pseudo seizures or non-epileptic psychological based seizures. Less likely to see that in the older population. Temporal lobe epilepsy in general is less common in the older population. And what we think of as being a primarily generalized epilepsy is more of a genetic syndrome, and that's less likely to come out in the older population. And none of these things are impossible to come out later in life. They're just a lot less likely. The more likely causes, and I think the biggest explanation for why there's such a change over time, is cerebrovascular disease. So we're not great at fixing everything in neurology, but we are a lot better at preventing disability after strokes. We're good at lowering risk of strokes. People are living longer after a stroke, but then the people who have a stroke are more likely to develop seizures. And I think that may be one reason why we're seeing more seizures in older adults now than we have in the past. Cerebrovascular disease is more than just strokes, but we think that that is a big chunk of what's going on here, and that might explain 30 to 50% of late onset seizure disorders. Another big chunk is degenerative diseases. We probably haven't made such a big dent in how well people are surviving those, but we like to think that we're trying, and that probably explains between 10 to 20%. The other causes are varied. Head injuries can certainly cause seizures, and I've seen seizure disorders develop decades after a head injury. So it doesn't have to be right away, it can be later, and that could come out later in life. Older people might be more prone to falls and injuries too, and then develop secondary seizure disorders. Brain tumors can happen anytime across the age spectrum, and it can count for a significant portion of older onset seizures. Less likely, but still we see it. We see survivors now from cardiac arrest. We didn't usually have survivors of cardiac arrest decades ago, but now with defibrillators everywhere, and we've got improved outcomes, improved survival. So we're seeing more survivors, and some of them may have a mild degree of head injury or a major degree of head injury from the cardiac arrest, which can be associated with seizures. Definitely another cause of seizures in older adults is any underlying systemic or metabolic disease. Infections can cause seizures. as well as there can be autoimmune disorders that can cause seizures, or general cancer conditions that can cause seizures in older adults. And then even though we have all these good explanations, there's probably still a good chunk of people who we just can't explain why they're having seizures. And that's got to be at least 25%. And that can be kind of frustrating not to know why. What are the risk factors? Well, I think I made it clear on the last slide that dementia and cerebrovascular disease can be risk factors for developing epilepsy later in life. For this study, atherosclerosis risk in communities, that was done and published in 2018, they really laid out all the different risk factors that can be seen with epilepsy and tried to put it all together. So they found, you can see stroke really did increase the risk of epilepsy. This line here, really that's no change in risk of epilepsy. And then things to the left mean less likely to develop epilepsy, and things to the right are more likely. And stroke was the #1 thing that was likely to lead to a seizure disorder. Dementia was also up there. This ApoE4 allele thing, that's a genetic risk factor to develop Alzheimer's disease. So by itself, even without dementia, that seemed to increase risk. Diabetes, especially in the Black community, really increased risk of epilepsy. And what we're finding is that it's not just the actual stroke or dementia, but it's the risk factors of those conditions that seem to be associated with epilepsy. So even hypertension, which is high blood pressure over time, which greatly increases risk of stroke, that by itself increases risk of a seizure disorder. So what I picture it as is the same underlying blood vessel problems that you're causing that make you at risk for stroke are already causing problems in the brain, making you more at risk for seizures. Smoking did increase risk, but not as much of an amount. Exercise was slightly protective, and alcohol use, 1 drink a day, was slightly protective, but more than that was not. And they not in this study, but another study also found that cholesterol, regardless of whether or not the patient had a history of stroke, could also be a risk factor for late onset seizures. Looking in a little bit more detail about stroke and late onset epilepsy, early seizures after a stroke don't necessarily mean epilepsy. They can be what we call acute symptomatic seizures. So someone's having a stroke right at that moment, or maybe within the week, and the actual blood clot itself or the actual bleeding in the brain is very irritating to the brain and can cause a seizure. It doesn't necessarily mean that somebody's going to go on and have more seizures in the future, but they are at higher risk. The rate of actual early seizures after a stroke is about 3%, and that would be within the first 2 weeks. Post-stroke epilepsy is very common, and you see it in about 3 to 11%, depending on what kind of population you're looking at. About one year after a stroke, around 5% of people will have developed a seizure disorder. If you follow them long term, more like 11%. So the numbers just go up over time, but it's not a huge bump after the first couple of years. Like I said earlier, as with any brain injury, that brain will always be at a higher risk of developing seizures, even decades in the future. So overall incidence, so if you take 1,000 people, it's about 18 to 23 per 1,000 per year will develop epilepsy after a stroke. And overall median time is about 237 days. So not right away, but takes some time, but most likely in the first year or two. Some interesting findings that we've seen in the literature when they're looking at risk factors for epilepsy after stroke, they found that being treated with a statin, which is a specific category of cholesterol medication, seemed to reduce the risk of post-stroke seizures. And I don't know that it relates anything to do with how it works for cholesterol. It may relate more to its anti-inflammatory benefits or some other mechanism of action. We're not sure about this at all. It's just a finding that's been seen, so it needs to be studied for further evaluation. Most people after a stroke are recommended to take one of these anyway, but it could be a way to reduce the risk of seizures in people moving forward. So I showed you how people with stroke are higher risk of developing epilepsy, but late onset epilepsy is associated with a higher risk of stroke. So if you develop seizure disorder after the age of 65, you're more likely to have a stroke than somebody who didn't develop a seizure disorder at that time in their life. So there's something called the hazard ratio, which is sort of looking at risks, and the risk for stroke after having a new onset seizure disorder later in life was about 2.89. So increased. And then the next big category of causes was dementia. Okay, dementia can be associated with the development of late onset epilepsy. But look at this, late onset epilepsy is associated with an increased risk of developing or being diagnosed with dementia. So the hazard ratios, like I told you before, kind of similar, a little bit lower than with stroke, around 2. And it goes both ways with a similar risk, about double risk. And what type of dementia is associated with seizures? There are different types of dementia. The most common, the one that's most talked about, is Alzheimer's disease. A person with Alzheimer's is about 10 times as likely to have epilepsy as someone without Alzheimer's. And about 13% of people with Alzheimer's have a seizure disorder. So it's not everybody, but it's pretty common. Dementia with Lewy bodies has very similar numbers to Alzheimer's. It's a different type of dementia that has some features that overlap with Parkinson's disease and can also be associated with some hallucinations. Frontotemporal dementia is a different kind of dementia. And the risk of epilepsy with that one is a little bit lower than the others. Overall seizure risk is about 3%. But the interesting part of frontotemporal dementia is I actually see these patients not infrequently because they can have what we call clinical fluctuations, and they can have spells that look like seizures where they just suddenly become unresponsive, or they have weird changes in behavior that are very concrete, short periods of time that come and go that sound or look just like a seizure. But they're not seizures, and sometimes it can be very difficult to tell unless you do EEG monitoring for an extended period of time to really decide what those episodes are. Frontotemporal dementia is also associated with myoclonus, which can be a seizure. Myoclonus is a very quick muscle contraction that can be anywhere on the body. It could be in the neck, it could be in the arms, it could be in legs, it could be in the trunk. It's usually a split second and then it's over, but it could cluster. If it's in the leg or the trunk, can lead to falls, it can lead to injuries, but it doesn't usually make people pass out. Myoclonus can come from the cortex of the brain, the outer layer, and that can be a seizure. But myoclonus can also come from other parts of the nervous system and not be seizure. So sometimes further testing is needed. Frontotemporal dementia is associated with a lot of myoclonus, especially late in the course of disease, which can sometimes cloud the clinical picture a bit. Looking at people who have late, so this is a graph showing you in the red, these are people with late onset epilepsy. In blue are people without late onset epilepsy. And you can see if you follow them over time, starting at age 67, and they chose 67 because you had to be in the study for at least 2 years before they'd evaluate your risk. So you can't have Medicare till you're 65. So that's why everyone had to be 67 at the point where we started evaluating. And you can see the cumulative incidence of dementia on the left-hand side. The absolute numbers are very, very low, 0.1, 0.2, 0.3. But you can see how these curves divide. So in someone with late onset epilepsy, they're more likely to develop dementia than somebody who did not have late onset epilepsy. Looking at Alzheimer's disease and epilepsy specifically, it gets really interesting. So like I said before, there's a good percentage of people with Alzheimer's disease who develop epilepsy at some point in their illness. Numbers range from 10 to 22%. People who have a genetic cause for their Alzheimer's disease are at higher risk. as are people who develop Alzheimer's at a younger age. So for example, somebody who's 50 to 59 at diagnosis has 87 times the risk of epilepsy compared to someone in the average population of the same age. What Alzheimer's, or part of what Alzheimer's is a buildup of something called amyloid in the brain. And there's a theory that that causes electrical irritability that can lead to seizures. In mouse models, amyloid beta can lead to epileptiform discharges seen on EEG and actual seizures. But then epileptiform discharges and seizures in the mouse are shown to increase the amyloid beta deposition. So it seems to be a cycle of irritability, especially early in the disease. And EEG abnormalities could even come before there's a clinical memory decline. So there's a lot of research interest in this area to see if seizures are part of early pathology, and if they are, can we do something about it? Seizures in Alzheimer's disease can be tricky because the seizures may be too deep in the brain. We're talking about the inside of the temporal lobes, which is very, very deep in the brain. And it can be hard to see on an EEG that's measuring brain waves on the top of the scalp. Some of these seizures may have no symptoms. So you may not know, even if you're looking at somebody, that they're having a seizure. We do know that seizures seen on an EEG are more common in Alzheimer's disease compared to the healthy population. And seeing abnormalities on an EEG are more common in those with Alzheimer's compared to the general population. The problem is that having the abnormality on the EEG doesn't guarantee that actually the patient's having seizures. You're more likely to pick up something if you have an EEG done during sleep, and longer EEGs may be more helpful, especially if there's some event that can be captured, and especially if sleep is captured, because we're more likely to find abnormalities. I'll talk a little bit more on EEG later, I think. A little bit more on Alzheimer's disease and epilepsy, and I don't love talking about animal models and basic science research because it doesn't always translate well into the clinical research and our actual clinic population all the time, but I find this really interesting. So when looking at Alzheimer's disease in animal models, specifically mice, they gave various seizure medicines to see how it affected the symptoms in the mouse of Alzheimer's disease and whether it changed the EEG signs of seizure. And they found that levetiracetam, which goes by the name Keppra, reduced the EEG signs of seizure potential, and it actually seemed to improve the mouse function over time. A number of other medicines were tried that had no clear difference, either clinically or on EEG. And then there were actually a couple of medications that increased the abnormalities on EEG, specifically phenytoin, which is Dilantin, and pregabalin, which is Lyrica. So we don't know how this translates into humans, but there are people looking at levetiracetam and Keppra basically to look at it as a therapeutic target for Alzheimer's disease to see if applied early in the course, or maybe at people at higher risk, maybe it could do something about actually preventing or minimizing progression in Alzheimer's disease. To jump a little bit to another topic, there's something called late onset epilepsy in Down syndrome. And people with Down syndrome have an extra chromosome number 21. So they tend to get dementia when they're in their 50s, earlier in life than in somebody without a chromosomal abnormality. And often these patients have seizure disorders as well. So about 38% of people with Down syndrome who develop dementia will develop seizures. Median age is around 53. And they tend to get myoclonus, so that quick jerking movement that I described before. But they can also get other seizure types. I've seen generalized seizures, absence seizures. They could really have any symptom. So how are older adults different in other ways? Well, what do they look like when they're having seizures? Younger adults with focal seizures, about half the time they'll report a specific aura and then change a level of awareness, maybe have a behavioral arrest, some automatic behaviors like lip smacking or hand movements, gestures, and then it'll stop after a minute or two, and then they'll be confused for 5 to 15 minutes, something like that. In an older adult with focal seizures, there's more variability. They might just have muscle jerking, or they might just have sensory changes, or they may just be able to describe their aura as being dizziness, or something very vague, or I can't describe it, or maybe they're just missing time. A lot of times people are accused of having delirium, which is like an altered sensorium due to medical illness for the most part, with waxing and waning over time. Often they're attributed to syncope, which is usually caused by a lack of blood flow going to the brain, causing someone to pass out, fall limply to the ground because the brain isn't getting enough blood flow. That can be a common symptom in older people. And if someone's passing out, they might not think of seizures. They might think it's, oh, something to do with the heart or something to do with the blood vessels or blood pressure. Older adults can have seizures, but they just stare blankly, but they don't get those automatic behaviors. So it's not so clearly a seizure by somebody who's witnessing it. And they may be more confused for a longer period of time afterwards. There are reports of somebody having a transient focal seizure, but then was confused for a week afterwards. I mean, they may not recover as quickly. They can also present in status epilepticus. Here's another U-shaped curve looking at incidence and events of status epilepticus according to age. And again, under 1, big time for status epilepticus. But then you see on this curve, anybody over 40 also beginning to be high risk. What status epilepticus is a seizure lasting more than 5 minutes in duration that basically doesn't stop on its own, and it usually needs a medical intervention to make it stop. It could also be defined as repeated seizures over and over without return to baseline in between. And so overall, it's 5 to 10 times more likely in older adults than younger adults. And if status epilepticus is a focal seizure, meaning it's only affecting a small area of the brain, someone could just be confused for a long time without going into a big convulsion, no tonic-clonic seizure, no shaking, no big dramatic event. They're just confused. And it's because a small part of the brain is seizing and it's not stopping. And that's why the person's confused. And most of the time in older adults, they're presenting in status epilepticus because they don't have a seizure history and they're not on any seizure medicine. So their first seizure just doesn't stop because there's nothing in there to stop it. Older adults are a higher risk of complications and death related to status epilepticus than younger adults. So doing tests to figure out what's going on is challenging. Less than half present with that typical symptoms that I described before. Half are presenting with focal seizures with impaired awareness without a bilateral tonic-clonic big shaking event. And about 30% of them aren't aware of their focal seizures. So there has to be a witness. And even if there is, the clinical features can be very subtle. Maybe there's just a little eye or face twitching or something to trigger it, or maybe there isn't anything to trigger the thought that this is a seizure. So they're very underdiagnosed. Testing can be less helpful in the older adults because it can be negative even when there's something going on. Or testing can be less helpful because it's showing you some abnormality, but the abnormality doesn't say for sure that it's seizures. And I'll get into that in a few more slides. History can be more challenging because of the confusion after a seizure, no memory of the event. Someone may have cognitive or language impairment during or after the event, so they can't relate what they're feeling. And if there's a baseline cognitive or memory or language impairment, if somebody has a mild form of dementia, they're not going to be able to relate the story as well as somebody who didn't. Older people sometimes aren't employed. So if no one's around during the day witnessing them, no one's going to notice these things are going on. They may be socially inactive, especially now or in the setting of a pandemic where people are afraid to leave their homes. Other people aren't going to notice anything's wrong. And if someone lives alone, again, less likely to have a witness. A diagnostic delay has been well recognized in older adults. Most people go more than 6 months before getting a good diagnosis, and it's longer in those who live by themselves. Symptoms are often attributed to other medical conditions. There was a study of VA patients, and the primary care doctor didn't suspect seizures at all in the initial evaluation in about a quarter of patients. They said there was something like altered mental status or confusion or blackout spells or syncope, but they didn't even say maybe this is a seizure disorder. What other things can we think about? So I mentioned briefly before syncope. So that's loss of blood flow to the head, causing someone to pass out. Arrhythmia, so an irregular heart rate can cause similar symptoms. Same thing with heart failure, low cardiac output. Strokes can cause sudden neurologic symptoms that could mimic seizures or vice versa. People can have movement disorders where they shake on one side of their body and you don't know if it's a seizure or movement disorder. I'm going to speak on the next slide a little bit about transient global amnesia, because that can sometimes be a seizure mimic. Sleep disorders can also be confused with seizures, a sleep attack or a parasomnia where people walk in the middle of the night or do funny behaviors out of sleep. People can have psychiatric conditions that look like seizures, including hallucinations or psychological seizures. They can have this catatonia state where they don't respond to anybody, but they just don't move. Dementia, memory impairment. I mentioned dementia with Lewy body can be associated with those clinical fluctuations that can't be, they're not obviously seizure or not seizure. You need to do testing. Migraines and vertigo spells can sometimes be confused with seizures. Drugs, medications can cause seizure-like symptoms for some people, as well as some endocrine and metabolic syndromes. Somebody has a drop in sugar, they could feel dizzy, funny, not respond for a few minutes. Same thing. So when we're thinking about vascular events, we're usually thinking about strokes. But then if you're thinking about something that mimics a seizure, you're talking about something that's transient. That's a very brief episode. So transient ischemic attacks, also known as mini strokes, tend to have symptoms between 2 to 15 minutes in duration. So they can be confused with seizures. The only thing is that with TIAs and strokes, they tend to have very stereotyped symptoms based on the blood supply that happens in the brain. So they're very specific patterns of symptoms that we look for these when we're evaluating patients. So you can even have limb shaking related to a TIA when there's a carotid artery, the main carotid artery, the main artery in the neck that goes to the brain. When it has a loss of blood flow, it can cause your arm to shake. So looking at the total picture and trying to look at, do the symptoms recur? What were the feelings before and after? Try to figure out whether it was a TIA or a seizure. Another example is that when people have speech loss due to a TIA or stroke, it's a very specific pattern of how they lose their speech versus seizures tend to be more vague symptoms. The syndrome of transient global amnesia is actually very clinically interesting to see. Usually lasts longer than a typical seizure, around 6 hours, and by definition has to be completely resolved within 24 hours. And it's an acute form of amnesia where basically all new memories fail to be formed into long-term memory. So people sound like a broken record. They keep asking the same questions over and over. They remember everything perfectly fine up until the time the event started, or maybe a couple hours beforehand. And then once it's ended, the memory is perfectly fine moving forward, but they never regain the memories during that brief period of transient global amnesia. They're able to talk fine, they're able to answer questions, they're able to respond appropriately, but they're not able to just form those memories. After a few minutes, they've completely forgotten what you said, and you wind up repeating the same thing to them over and over again. It's a very interesting syndrome. It has nothing to do with strokes and it has nothing to do with seizures, but it's often confused with either one of them. So how do we tell what's going on? What tests do we do? Well, getting a history, finding out what happened the day prior, the day of, is really, really important. Sometimes we do an EKG because cardiac rhythm disturbances are, I think, a really important thing to make sure is not going on before you tell someone they have a seizure disorder. Sometimes we do blood tests. I need to know every medication, drug exposure, anything that might have been taken. And at the back of the head, always consider things like drug withdrawal from benzodiazepines or alcohol, because that can trigger seizures in anyone, or drug intoxication, because that can mimic a lot of other symptoms. We typically do an electroencephalogram. You can see a nice picture here with electrodes on the brain and the squiggly lines that I love to look at all day. So a routine EEG generally only records for about 20 minutes. And in an older person, the yield is low. So the sensitivity is probably around 30% in those with epilepsy. And what that means is that more than 60% of those with epilepsy in the older adult population, more than 60% are going to have a normal routine EEG. So it's not a very reassuring test when it's normal, but if it's abnormal, it's more helpful. The problem is that the abnormality might just be something called slowing or something else that's not specific for seizures. It's just an abnormality saying something in the brain's not working at 100%. The things we look for seizures are generally spikes and sharp waves, real big disruptions of the EEG that show a potential for seizure. That's what we want to see as an explanation for what's going on. EEG is more likely to show something in someone who has at least one seizure a month. It's higher yield when sleep is captured, and it's higher yield in longer studies, mostly because you can make sure to get sleep. Inpatient video EEG is underutilized. It often comes up with non-epileptic explanations for events and seizure-like activity in older adults as well as younger adults. It can be very helpful at sort of clarifying a diagnosis when it's not responding right to the meds or when there's confusion about it. MRI and CAT scan of the brain is a pretty typical test whenever we're concerned about seizures. The problem in older adults is that we all tend to build up a little wear and tear over time. There's something called non-specific T2 hyperintensities, which are white spots in the brain tissue, and it's not uncommon to get a couple per decade of life. And as you get older, that could be quite a few spots to build up. Some people can get atrophy or thinning of the brain tissue. It doesn't mean there's a higher risk for seizure, but it's not technically normal. So of all comers, the brain imaging is going to be abnormal in over half of them, but only about 20% will show a sign or some reason to have seizure. And of those, most often we're finding some sort of stroke or cerebrovascular problem, some scarring that might relate to seizures. Treatment considerations. How are older adults different? Well, generally, we don't want to put someone on seizure medicine unless we think there's a high risk for having recurrent unprovoked seizures. So in general, that's only offered after one seizure if we think the second seizure is likely, meaning an EEG showed a tendency for seizures, or the MRI shows a reason to have seizures, or someone really doesn't want to risk having a second seizure and they'd rather be on medicine rather than have another seizure. So one reason to treat after just one seizure is because seizures in an older person can be very risky. Older people are more likely to fall. They're more likely to break a hip if they fall. They can have cardiac stress. I've seen elevated cardiac enzymes after seizures because it's so stressful on the heart. And preventing recurrent seizures may be very appropriate even after just one. If we have abnormal testing after one seizure, you can make a diagnosis of epilepsy now, even with only one seizure. In the past, you used to have at least 2 seizures before you could make the diagnosis. On the con side of that argument, don't treat after just one seizure, is that seizure medications can have side effects. And you don't know for sure that if somebody has just one seizure that they're going to have another one. And there's risks to combining medications that can be more significant in an older patient. If you do treat somebody for seizures and you're sure that they have epilepsy, how do they do? Well, the good news in all this is that they're more likely to be seizure-free on their medicine than a younger person. Seizure freedom is in the 80 to 90% range in older adults, which is much higher than the younger population. And most of those older adults are seizure-free. 94% of them are seizure-free on one medicine. Most of them are at modest doses, so they don't need tons of medicine at high doses. It's a lot more optimistic. Interestingly, another association that's come out in the literature is that aspirin use seems to be associated with a lower rate of seizure freedom, but I wouldn't take this to mean anything significant at this point. This was just a finding in a study, and we don't really know why that would be. Maybe it changes metabolism or vascular risk factors. Maybe it's just because if you're on aspirin, you're more likely to have cerebrovascular problems that might lead to harder to control seizures. We don't know why this association is seen. So if you're an older adult and you're on aspirin and you have seizures, don't just stop your aspirin. Talk to your doctor first. Side effects are really common in older adults. Many of them are taking multiple medications, not just the seizure medicine. And the side effects can really add together. There's more likely to have drug interactions when you add multiple medicines. Um, Kidney function generally does decline over time in everybody. So that can lead to higher levels of medications in the system. Liver function can decline, but it doesn't always, it's variable and it's hard to predict. But in general, we might be able to get away with lower doses because the medications may be staying at higher levels in the blood. A lot of medicines bind to protein in the blood, and the protein level can be lower in older adults. So that can lead to misinterpretation of blood tests for some people. Side effects are reported at lower doses and lower drug concentrations in older adults compared to younger adults. Most common, the side effects are pretty similar to those seen in younger adults: tiredness, dizziness, poor coordination, shakiness, vision problems. The main difference is that older adults are more likely to report confusion compared to younger adults. Drug levels can be more variable in older adults compared to younger adults, but every body is different. There was a study of nursing home residents done a long time ago where they did phenytoin levels or dilantin levels in nursing home residents over the course of many days at multiple different times a day in many different patients. And they found that even without changing the dose or formulation of the medication at all, no drug interactions, the levels would fluctuate 2 to 3 times in serial measurements for no clear reasons. But this wasn't seen in everybody. It was only seen in some people. And when they measured some other medications, not just seizure medicines, they found the same kind of variability. So the question is, maybe older adults maybe have some age-related changes in terms of how well the gastrointestinal system absorbs medication. So we have to keep that in mind. Things can be like a roller coaster and they can go up and down. So do we know which medication to use? Is it different in older adults? There have been some studies looking at this. 3 randomized trials, meaning they took everybody and just randomly put them on one of a couple different medicines, found that there was similar seizure control between a variety of medicine. And that's not surprising. That's kind of what we see everywhere, is that most medicines have about the same likelihood of actually working. The way the medicines really differ is in terms of their side effects. Tolerability really varied between the medications. Lamotrigine had the best tolerability amongst all the medicines tested. This one study that compared a bunch of medicines found 12-month retention rate at 78.6%. So almost 80% of everybody who started it found it tolerable enough to stay on it at a year. Levetiracetam, which is Keppra, similar at 74%. And you can see the other medicines listed below didn't do so well. Phenytoin, gabapentin, topiramate, and carbamazepine were all around the 50 to 60% retention rate. And then oxcarbazepine, which is trilaptol, didn't do so well, 23.5% retention rate. Other studies found similar comparisons between the drugs, and valproate, which wasn't mentioned up there, did not seem well tolerated. What else do we think about with medications? Well, medicines that work on sodium channels, and this is a lot of seizure medicines as well as some other medicines, can have a potential to cause an irregular heartbeat because there are sodium channels on the heart, not just the brain. The real risk is probably very low, but it's probably more common in people who have heart disease, and the risk can be additive. So in general, we try to avoid using more than one drug that can affect sodium channels in older adults. Unrelated to that is a problem called hyponatremia, which is a low level of sodium in the blood. It's most often seen with oxcarbazepine, which is trileptal, carbamazepine, which is tegretol or carbatrol, eslicarbazepine, which is Aptiom. The risk increases when combined with other medicines that can cause a low sodium, including diuretics, which are water pills, and SSRIs, which are the most common form of mood medications. Despite probably a strong inclination to try this, eating more salt like potato chips doesn't help fix the problem. Really, if it's a big problem, you have to come off the medication. Something I'm concerned about in my older patients, as well as patients who might be on seizure medicines for a long period of time, is bone health. Osteoporosis is very common in any older woman, and it's a much worse problem in anybody on a seizure medication. Epilepsy can increase 2 to 6 times the risk of fracture in an older person, and this largely probably relates to trauma and falls. Seizures can cause injury when they occur, especially if they're motor seizures. People may also have a neurologic disability like weakness, poor coordination that relates to fall risk, and then medication side effects. If you're dizzy on your medicine, you're more likely to fall and injure yourself and get a fracture. We do think that there are some seizure medicines that can hurt bone health. And it's been proven that people with epilepsy have reduced bone health. So medications can cause this because they can have interactions with sex steroids in the body affecting bone health. They can metabolize vitamin D, lowering vitamin D levels, which can impair bone health. And maybe the medicines have a direct effect on bone. We know this happens with phenytoin, phenobarbital, and valproate, but we don't know about the newer medicines. People with epilepsy may also have poor bone health because they may not be as physically active, and weight-bearing exercise can improve bone health. Diet and depression may also play a role in reducing bone health. So these are a big concern. What can we do about it? Well, we don't have great guidelines. What we usually do is I recommend normal calcium intake, vitamin D supplementation if the levels are low, and most people are low around here. Weight-bearing exercise and not smoking are the other things that we can do for bone health. There's something called a DEXA scan, which is a way to monitor bone density to evaluate for bone health. Vascular risk can also be affected by seizure medications, particularly the older medicines can worsen cholesterol and inflammation tests. Switching medicines does seem to help, but the latest data shows that all people with epilepsy are at a slightly higher than average risk of vascular disease. Stroke patients have been found to have increased sensitivity to some medicine side effects. Specifically, carbamazepine was found to impair function and attention worse than levetiracetam. Like I said before, levetiracetam seems to have a good cognitive profile in Alzheimer's disease, but our memory disorders experts here tend to think that it may be associated with decline in mental health, may be related to depression and psychosis. So it may not be the best drug for everybody. Lamotrigine can help mood. Valproate has been associated with volume loss in the brain and cognitive impairment in kids. So we think that probably not the best thing for adults. And there's also something that was reported in the literature some years ago about the risk of dementia being increased in medicines that have an anticholinergic property. And this data is questionable, but if it's true, it would include the medicines carbamazepine and oxcarbazepine. And then dialysis can clear some seizure medicines from the blood, making dosing very hard. It's something else we have to think about. Other things we think about is mood, how the medicines can affect mood, depression, anxiety. That can be a big issue in the older population, and it tends to be underdiagnosed. Late onset epilepsy increases risk of psychiatric admission, especially in those who have alcohol use disorder. Our seizure medicines can affect weight. They can affect level of alertness, headaches, pain. So we have to think about those things as well as medication interactions when providing a prescription. And then for some people, when medicines don't work, surgery is an option for seizure control. And there isn't a lot of information out there on older patients. There are several surgical series looking at resection in older people and finding that it can definitely still be successful and make people seizure free. but the cognitive outcomes, especially in left-sided surgery, may not be as good. And stimulator therapies, vagus nerve stimulator, responsive neurostimulation, deep brain stimulation is definitely still options for older patients, but they are not well studied. So we don't know if the response rates are different, but they are considered safe at this time. So my general advice is to make sure you have the right diagnosis, know what you're dealing with so you know how to treat it. Maybe longer EEG testing is needed. And with medicines, always try to get away with the least amount of medicine with the least number of side effects and least amount of drug interactions. And if medicine doesn't work, surgery can still be an option, even if someone's on the older side. And that's it. Sorry, I ran a little later than I wanted to, but I'm happy to take questions at this time.
Thank you so much, Dr. Bunch. If there are any questions, I would welcome you to go ahead and unmute yourself if you'd like to just go ahead and ask something. I believe everyone should be able to unmute yourself. If not, you can shoot me a quick message, or I think there's a raise your hand function. One question that I actually had is in regards to diagnosis. So, you know, obviously we reviewed the challenges that there are with that differential diagnosis, but I wonder if there's any, I don't know, evidence that maybe a piece of why we see that increase in the incidence of epilepsy in older adults, you know, especially over time, you know, over the past 2 decades, has anything to do with better diagnosing.
That's a really good question and suspicion. And I think I don't have any proof, right? And I'd like to think we're all better doctors than we were 20 years ago, but I don't know that that's necessarily true. I know that there probably is more availability of long-term monitoring now than there used to be. So I think that definitely has helped, but I think in a way that also helps exclude epilepsy as much as it does to prove it. So I don't know. Honestly, you know, we all wish we had a crystal ball and a time machine at times, right? Like go back in time and do certain tests and see how things are different.
Yeah.
But I think it's gonna take time to figure out whether that's, you know, whether we're just missing it before or whether it really is more common now.
Thank you. We did have a question asking how do you feel about medical marijuana in this population?
Great question. I think it's complicated. So it's not well studied in general for focal epilepsy, which is really what we're talking about in this population. It's best studied in kids, unfortunately, with very specific syndromes. There are definitely a few studies out there looking at it with people with focal epilepsy. But I don't think the population of older patients was very significant in those studies. And I don't think that in general for focal epilepsy, it's as much of a dramatic response as it was for some of the kids and those more genetic epilepsies that have been shown to where cannabidiol specifically has been shown to be helpful. It does have side effects, particularly in an older person. I would worry because cannabidiol at the doses that you need for seizure control can suppress appetite. And sometimes we're already worried about weight loss. For some people, it can cause elevated liver function testing, particularly when combined with valproate, otherwise known as Depakote. And it does have drug interactions. So we need to be aware of those things. So I think it may be helpful, but there are other things that are better studied and more easily available right now.
Great. And another question is about dietary interventions, so ketogenic or other diets.
Yeah, great question. I don't think I've seen very much literature looking at older adults specifically. Again, those things are really well studied in kids, and there are definitely some studies looking at adults with ketogenic diet definitely can be effective. Again, you worry about weight loss, you worry about kidney stones, you worry about constipation. I think the biggest problem with the ketogenic diet in adults in general is just it's very hard and very intense kind of diet. I don't think I've ever had an older adult try it or even express much of an interest in doing a diet at that point in their life like that. In general, if somebody needs to lose weight and we're looking at improving seizure control, I have them look more towards things like the low glycemic index diet, because I think it's a lot probably milder and safer and probably a lot easier to do long term. But it's a great question. I don't think I've seen anybody look at it in older adults. I'll go look for it after this talk.
Awesome. And another question, why does a seizure come out of the blue? And the context is their parent was visually fine for the 2 hours prior, but then a focal seizure occurred.
The $1 million question. Seizures tend to come, there's a number of different things that all probably have to align together to make a seizure happen. There's certainly times of days that can be triggers. There can be sleep deprivation or certain medication levels or certain other triggers, stressors, that can come out that can make a seizure happen at any given point in time. I think that's the scariest and kind of the worst part of epilepsy is the unpredictability of it, in that even in somebody with a seizure disorder, you never really know when it's going to come out, and why a first seizure would come out at any very specific point in time. Sometimes we just don't have the answer to that. It's like I said, with stroke or with any kind of brain injury like head trauma, it's not even, you can get symptoms right away symptomatically, but that risk for seizure goes on for decades, and why the seizure comes out 12.7 years after the stroke or 13.8 years after the head injury, why it chooses then, we really don't know.
Are there any negative interactions between seizure meds and Prozac?
Prozac has a number of drug interactions with it. Off the top of my head, I don't know of a seizure medicine that tends to interact with it a whole lot. I will say that Prozac is in that SSRI antidepressant family, and those medicines do at times lower sodium levels in the blood. So the medicines, some of the seizure medicines can do that. I think I see it being a problem the most with oxcarbazepine or trileptal. So if somebody's on Prozac and trileptal, I make sure that I check a sodium level at least once a year, once they're on stable therapy, just to make sure that sodium level doesn't keep drifting downward over time.
Thank you so much. Are there any final questions from anybody? And I am going to put my email address into the chat, so everyone is welcome to take that down. And if you have questions, you can send them to me, and I'd be more than happy to pass them on to Dr. Bunch and get that answer to you. Oh, we did have another one come in. Do nitrates and artificial sweeteners contribute?
I haven't seen anything specifically that slam dunks and just blames those things for sure.
All right. So as I said, please feel free to take my email down in case any other questions come up later. Happy to facilitate getting an answer for you. And I want to thank you all so much for attending today. I will make the recording available if you want to share it with anybody else. And the other thing I just want to mention before we sign off is that we're going to have a lot of programming in November for Epilepsy Awareness Month. So please keep an eye out on emails, on our social media, our website, for all of the upcoming webinars and different topics that we'll be offering. So thank you so much. Thank you, Dr. Bunch. It's a pleasure as always. And I hope everyone has a really great afternoon.